Always feels that way. Okay, it's officially 12 o'clock. We can now begin. Thank you everyone for being here for today's session. We're really excited to have you here for our February AI session. Today we're going to be talking about an introduction to AI in clinical care. This is one part of our AI-enabled digital health services series. So please stay tuned for more to come on this, but thank you for being here today with us. We are wonderfully joined by Michael Gao and Mark Sendek from the Duke Institute for Health Innovation. They're going to be sharing a lot of great stuff with us today, so get excited. Next slide, please. As you know, we are in Zoom today. Everyone has been muted and your camera is off if you're an attendee, but we do not want you to see that as a deterrent from participating with us. So please open up that chat, say hello, ask your questions, add your comments. Please use that throughout the session. We will have some time at the end to go through some questions, hopefully. So please feel free to drop them throughout the session. Also, feel free to adjust your gallery speaker view as you need. Functions are available at the bottom of the screen. Next. Little disclaimer for you. As always, CTRC is here to provide information and education. We do not provide legal advice, and we have no relevant financial interest or arrangement with any organization, products, or services that may be mentioned in today's presentation. Just here for education. Our grant number is provided below. You will see we're wonderfully supported by HRSA for the advancement of the Office of the Advancement of Telehealth, and also through HCAI's CalSOAR office. Next. And now we'll hand it over to Sylvia to do some introductions of our speakers.
Great. Thank you so much, Aislinn. My name is Sylvia Trujillo. I'm the Executive Director of the California Telehealth Resource Center. So we are really delighted to have two distinguished guests who are practitioners in the field who are innovating and trailblazing. Before we jump into that, I do want to just provide a little bit of context. The California Telehealth Resource Center is really much more expansive than telehealth. We do digital health and virtual health, and that is what we're funded through both by the federal government, HRSA, and through state agencies like the California Rural Health Office and the agency responsible for health information. And we have a direct charge this year to expand educational content for clinicians, particularly in rural communities and community health settings like federally qualified health centers and critical access hospitals, for example, to really advance the work that has been laid out at the federal and in the state of California to ensure that AI systems, when applied in healthcare, are done so safely, that they are systems that are going to drive equity, drive sustainability, improve outcomes, and for lack of better characterization, are going to advance the quintuple aim. So with that context, I would like to share with you that we have an 8-part series. Michael Gao is here today, along with his colleague, Dr. Sendek, both of whom really I've had the opportunity to see their work and learn about their work dating back many years. Duke has been a pace setter in this space, innovating, but really critically, and they'll talk about today the work that they're doing to innovate and improve clinical practice and equity and using AI systems to do that. But they've really been strongly committed to education along the way. So Dr. Sendek was one of the first physicians that I had the opportunity to interact with at my former employment at the American Medical Association, and worked with a lot of physician leaders to help them understand really basic fundamentals around what do you mean by healthcare and AI and the modalities and applications. So up here on the screen, you can read rather a little bit about Michael and his incredible work as a data scientist to advance the work and to make sure that stakeholders are brought together and understand the endeavor. And here you can see just a couple of the hats that Dr. Sendak wears. So in addition to his work with Duke, he's the co-lead of the Healthcare AI Partnership. He's published extensively, has been a co-editor and an editor of some publications about best practices. But I think he's most famous for his debut before the U.S. Senate's Finance Committee, where he talks about healthcare AI and really the critical importance with members of the U.S. Senate in a committee that really makes a lot of important policy decisions about healthcare, the importance of engaging and democratizing AI and healthcare for everyone, not just for elite institutions like Duke or Stanford or UCLA or UCSF, but really how do we think about it? And so he and Michael are here today to talk about that. So with that, I'm going to have the slide advance and thank them for their incredible contributions. We appreciate it.
Alrighty, thank you for the wonderful introduction. We're happy to be here today. Just as a quick check, can everybody hear me? Mark, can you hear me?
Yeah.
All right, great. So we had a pretty broad title to sort of kick this off. We're just looking at the introduction to healthcare AI. I think one of the most interesting topics and sort of topical today, at least, is the use of generative AI in healthcare. And so I think what I want to do is take some time today to talk through how we got to where we are today when it comes to generative AI, where some of the potential is, and then maybe talk through, if you are presented with one of these tools, what might be a framework that you could use to actually implement these things. We, Mark, me, and others at DIHI have been working in, sort of the forefront of implementing AI for let's say the past 6, 7, 8, going on 8 years now, and have learned a few things and would like to share some of those with you. I think at any point throughout any of this, if any of you have any questions, please feel free to just put them in the chat and we'll address them, or if we don't get them today, we'll be happy to address them later. So what I want to do today is talk about where we are in terms of generative AI technologies, how we got here, maybe a little bit of a primer. I think we mentioned a little bit about educational resources. We'll teach you a little bit about how we got to where we are when it comes to generative AI and large language models. And the hope there is to try to give you a sense for, where some of the pitfalls might be, how do these technologies actually work, maybe demystify some of them. And that'll lead into, I think, naturally how we use them in the healthcare setting. And then we'll talk about, a very common use case right now in generative AI, which is virtual scribes. I'll go over a use case at Kaiser and talk very briefly about where we're headed, although I think that will leave us with plenty to talk about. So, I think generative AI, we talk about things like ChatGPT and similar technologies, obviously have a ton of impact throughout all aspects of society. I think especially within healthcare, there's a lot of energy right now around how we can apply these things. When it comes to the provider front, anything automating some of the billing or documentation is one of the use cases, patient-facing chatbots. And throughout healthcare in general, there are just so many different use cases that people come up with. And I want to talk a little bit about how we got here, what the technology actually is. So we're not just talking in generalities and maybe more specifics. And sort of in my background, sort of researching machine learning methodology, I've sort of seen the meteoric rise of large language models and want to talk through, how we currently use them. So most of the generative AI use cases today are based off of things known as large language models. You might have heard of ChatGPT. I'm sure everybody's familiar with that. And really, there are maybe a few fundamental, let's say, tricks that have happened in the research since about 2017 or so that have enabled these. But mostly it's going to be the size of the compute. So, and the size of the models themselves. So actually in 2017, Google published the original transformer architecture paper, which in which they fit a language model that had 200 million parameters. And you can think of parameters as, sort of a rough sense for, how many like knobs you can tune in the model. So 200 million is quite a lot, and we thought so at the time. But since then, some of the more state-of-the-art models that you might be used to, for example, GPT-4, and if you pay for ChatGPT Premium or Bing or Gemini, you may have heard of these, are on the scale of roughly 1 trillion parameters, just to give you a sense for how large these models have gotten. And that's sort of what has spurred on a lot of these downstream use cases as well. So how do these models actually work? I mean, actually, fundamentally, all these large language models really are just next word predictors. So really, we're using decades old technology in terms of using machine learning for prediction, and we're just using that to predict the next word in a sentence. So maybe we have, let's say, trillions and trillions of documents and blog posts, everything from the web, textbooks, internet comment sections, and we're just saying, can we build a model to predict the next word? And it might seem that that's kind of a simplistic way of training a model, but actually, it turns out that this is a surprisingly good task if you want computers to understand language. And for example, I have here on the right, and of course, I don't know anything about this, but there's a sort of a clinical use case here. There's a patient presenting with some symptoms. It's caused by mutations affecting type 4 collagen, specifically in the blank. In order for a model to be able to fill out the next word or predict the next word, it needs to encode something about, let's say, clinical understanding, which is far beyond my own clinical understanding. But you can see that being able to predict the next word would hopefully train a model to have some sort of internal representation for language and being able to predict the next word. It's actually quite a useful task. So let me give you an example of how we came from large language models to where we are today. So the original large language models were not the ones that you see on ChatGPT. They were exactly this next word prediction. So I've actually created an example that I had a friend come up with. And again, I think this is related to surgery. So the prompt would be, explain the advantages of a deep flap over a tram flap. And if we use the old school sort of large language models that just predict the next word, you can see that it actually pulls from a question and answer bank. So it's generating the next token or the next words. And it's basically just saying, oh, the next word that I expect is that this comes from maybe like a question and answer for step 1 or these other clinical exams. But it's not doing what you would expect when we interact with ChatGPT and these other tools today, where it's actually giving it to you in a nice format. So this is how large language models worked. Probably around 6 or 7 years ago. This was state of the art. And so what changes have happened for us to be able to now build all these tools on top of these models? The first thing that we did was called instruction tuning. And so if we wanted to get an answer for this question in the past, us like natural language processing people would have to basically trick the model. So what we would say is we would actually just fake it as if we were actually giving the answer and then have it auto-complete the answer. So we would change the prompt to say there are many advantages of a deep flap over a tram flap. And we would add a section that said maybe historically tram flaps, and then we would allow it to generate the answer. So we're kind of using this next word prediction and we're forcing it to give us an answer by auto-completion rather than it actually following our instructions. And so people realize, okay, well, maybe this isn't the best way to interact with these large language models. If only there was a way that we can have it actually answer the questions that we ask it directly. And so this is what instruction tuning allows us to do. So nowadays, when you ask, ChatGPT or these large language models to do this type of work, if they've been instruction fine-tuned, then they will actually go ahead and present you the answer. And the way you do that is actually not too different from how you train large language models in the first place, which is now you just give it a whole bunch of different tasks and you say, here's a task that I want to complete. And then you have it auto-complete with the answer that you want. And if you do this enough times over various modalities, then eventually the model, quote unquote, learns how to answer questions without just doing autocomplete. Okay, but under the hood, it's still doing a form of autocompletion. So what does it actually enable us to do? And I know we're getting a bit technical here, but I think it's very important to understand how these models work because it informs all of the possible downstream use cases. So we went from these next word predictors to now being able to answer questions. And this has enabled a whole field called prompt engineering. I put it in quotes because I don't know if it's the greatest name. But the idea is that actually when these large language models get large enough and they've been instruction fine-tuned, you can actually teach the model how to do things without modifying the model itself. So your prompt, in the prompt, you can actually give questions and answers in the format that you would like, and then the model will learn to do that task because it's seen as a function of its next word prediction, it can learn to do that. So here's an example of what we call few shot learning. Let's say we want to teach a model how to translate English into French. What we would do is we would give it example. So we would say, for example, like a sea otter, here's how you would say that, peppermint, here's how you would say that, and then cheese, and we would have it autocomplete this. And so these examples actually provide the language with sort of like an additional instruction on what to do. And it turns out that many papers have found that this approach is actually quite reasonable, and it performs better than if you don't do that at all. And this is where I think we start to unlock the power of prompting LLMs in different ways, which will eventually lead to some of the healthcare applications that we see. And I'll spend a few more minutes, and then we'll move past this. So one of the most popular techniques for this these days is called chain of thought. And I actually think chain of thought is a very exciting way of doing prompt engineering, because it is a lot of the processes in healthcare are quite complicated. And so maybe the large language models don't know how to do them right off the bat, but if you give it some examples, then it'll perform better. So here's a very classic and actually one of the most highly utilized prompt techniques that exists today. And basically, it's in words, you're just explaining your work. Okay, so large language models often struggle with simple arithmetic. I'm happy to go into details on why that is offline if you want. I have many thoughts on that. But on the left, we have a standard prompt, which is just, I think, like a fifth grade question, like word problem. And the model in this paper actually wasn't able to get this question right. On the right, what we've done is we've modified the prompt where we just explain our reasoning for how we solve the question. And the model output is then able to mirror that reasoning and get the answer correct. And so this chain of thought is actually, it's a very popular technique. It's also very effective. And I think in many LLM solutions and generative AI solutions, this is one of the main tools that's being used. There are many creative ways to engineer prompts as well. It turns out that for some tasks, like the one I mentioned before with mathematical reasoning, people found that if you tell it to take a deep breath and work on this problem step by step, that has higher accuracy on this data set than some of these other prompts. Okay, so these are very black box techniques. It's not I would say it's more of an art than a science at this point. But what you put in the prompt and how you prompt can have a large effect on the downstream performance of the model on your task. Just as a funny sort of anecdote, somebody said, if I ask ChatGPT and I say that I will tip some amount of money, will it perform better on some tasks? And it turns out that if you offer to tip $200, it works better than if you offer to tip $20. And if you specifically say that you won't tip, it actually will provide you a worse answer. Okay, to give you a sense for how creative some people can get in terms of their prompting. Now that might be sort of like, tongue in cheek, but actually there are some very principled ways of prompting. And this is a great paper out of Microsoft that talks about different methods that you can chain together to actually perform very well on medical question and answer benchmarks. For example, just asking the question gives you maybe an 80% accuracy, but when you combine giving examples with chain of thought, like we just talked about, you can actually get up to 90% accuracy. So without modifying the model at all, just modifying the way that we operate on the prompts, we actually maximize the performance of the LLMs. And this is sort of an ongoing area of research and is definitely being used in many of the generative AI solutions that are available today. So what does this enable us to do? I mean, we've been able to build on technology since 2017 with these large language models, and we're now able to have it follow instructions. We can then provide examples for those instructions and have it be very accurate in a variety of use cases, medical question answering, mathematics, and so on and so forth. And, as sort of there are many, many healthcare applications that you could see as a direct result of just these large language models alone. One of them, which we'll touch upon, is virtual scribing. One of them is note summarization. You can populate registries from unstructured data to structured data, responding to patient messages, conversational AI for scheduling, coding, medical coding help, and so on and so forth. There are so many, anything involving documentation or text, I think is where LLMs might have an impact. To give you a sense for what virtual scribing, or let's say note summarization, you would just take one of these large language models, you would input the note, and then you would say, please summarize this note. if you wanted to perform even better, you could give it examples of notes that have been summarized before. This would be known as few-shot learning. And then maybe in chain of thought, you could say, oh, this sentence isn't very important. This sentence is important. Here's how I arrived at this summary, and that would be chain of thought. And so you can see how you can string together these prompt engineering techniques and to try to, essentially get to state of the art for many of these applications. So one of the things that I want to mention, because I think many of us are seeing a lot of vendors who are talking about these technologies. One of the things that's come to my attention is that actually the technology itself probably will not provide a moat for these companies and solutions. And what do I mean by that? Essentially, the LLM technology is sort of commoditized in the sense that anybody can do this type of work in terms of if you have a well-defined problem, you can come up with your own examples, your own chain of thought, and your own prompts. And then, maybe with a few software engineers, you can build out these solutions, or you can even try them out as a proof of concept. And so the real moat for these products in this space, at least from what I've seen, is going to be access to data for making sure that the models perform exactly how you want your institution's models to perform, and integrations into current workflows. We'll see an example later of a virtual scribe, which was not integrated into the EHR, but was a separate third-party application. And we see that actually there are a lot of the adoption rate suffers as a result of that. In addition, a lot of open source models have started to come into prominence. And just from my, playing around with them for the past year or so, I would say that they're roughly around 70% of the performance of some of these closed source models like GPT-4 or Gemini, and so on and so forth. I think this is an important area of research as well, because for things like HIPAA compliance or not sending protected health information to the cloud, these will become an important player in the healthcare space. So to give you an example of how commoditized this is, we talk about virtual scribes a lot. I just maybe 30 minutes, put together a demo for this. So I took a YouTube video on taking a clinical history, and then I used an open source audio to transcript or audio to text model, which generated transcript. And then I fed that into an LLM with a prompt that I created. This took me about 30 minutes, and I would say that most of the time was installing the software, probably 20 minutes or so. And so I ran this YouTube video, the transcript, it generated the transcript. This is an open source model that runs on my laptop, and then fed it to ChatGPT, and it came up with this note. Now, I haven't verified all of the contents of the note, but I think it shows that if I can put together like a proof of concept for this in 30 minutes, this type of technology is going to be commoditized in the future. So you're going to see the price come down, hopefully. I think a lot of the axes upon which you should evaluate these things are more on how well does it integrate with your workflow, how specific is it to your workflow. The technology is clearly there. It's something that I think I wouldn't say is going to be the main differentiator moving forward. Okay, so those are the upsides of large language models. I think I'd be remiss to not mention a lot of the downsides of large language models. One of them that you may have heard of is that large language models can hallucinate, or they basically get things wrong. And this is actually an inherent problem to large language models. So to give you an example, there's this paper that just maybe categorizes different types of hallucination. One of them is factual hallucination. So it just, gets things wrong when you ask it about facts. The other one, which I think is very important in this use case, is faithfulness hallucination. So, excuse me, given, let's say, some information from a transcript or whatever the case might be, if you ask it details about the transcript, sometimes it can get those wrong. And this is obviously a problem in a lot of healthcare, I would say most healthcare use cases. So one of the critical questions becomes, can we avoid this hallucination? Like, what work is being done to mitigate this? And although there is a lot that you can do, fundamentally, large language models will always hallucinate in their current form. And the reality is this is meant mostly because they're a probabilistic model over words. So they actually sample from a probability distribution what the next word should be. And you might just get unlucky and the next word might be something wrong. There are many ways to counteract this, but there's been some recent theoretical research on large language models showing that you can't, hallucination is actually like an inherent property of these models. That being said, there are a lot of software solutions to try to mitigate this from happening. So one of some of the things that people are trying is like, well, what if I run it through multiple large language models and take like a majority vote? Or if I run it through the same large language model multiple times and take a majority vote? What if I ask the large language model to read its own output and tell me whether it hallucinated? There's also just some more hard-coded verification chains, and then also uncertainty quantification. So asking it, hey, you generated this word. What was the probability of you generating that word? And if it was low, maybe we say, we should flag that as a potential hallucination. So even though there are these techniques being developed to try to prevent this type of, the errors in the LLMs, it's not something that we can fundamentally get rid of. And I think that's very important when we talk about use cases in healthcare, because one of the things that we have to think about very carefully is what is the cost of the large language model getting something wrong? And this will fundamentally affect how automated some of these tools will become. Do we need a human in the loop? Can we have it operate on its own? What are the costs? What's the cost of it getting something wrong? These are important questions that we should ask ourselves as we're using these tools and as we're evaluating whether or not they are going to be useful or effective for our use case. LLMs have also other problems as well. There's been quite a fair amount of work on bias in large language models and how they can perpetuate existing inequities. I think this is actually a very important line of work, and I'll talk more about it in the context of the case study later. But this was a great work that came out of, I believe it was Stanford. I believe so. Basically asking, these different large language models, Bard, ChatGPT, Claude, and so on and so forth, these questions that have been known to, include race as a predictive factor for, let's say, like calculating EGFR and so on and so forth, and had clinicians basically rate the answers on how problematic or, how they might actually perpetuate some inequities, and showed that for many of these questions, because it's relying on a bank of, potentially biased work, it's going to just repeat that. And so there's actually quite a bit of potential for this. Let's talk about some examples. So I really wanted to actually spend some time today and talk about what I see as a good way to evaluate generative AI products moving forward. So let's say your institution is provided with a generative AI product. How are we actually supposed to implement these things? What are things that we should watch out for? What's the roadmap look like? And one of the challenges, of course, is that I think that none of this is easy. Certainly, it's not necessarily as simple as just taking a product off the shelf and just implementing it. There are a lot of questions and design efforts that have to go into evaluating these things correctly. So I want to talk about that. And one of the key things that I want to mention is that the overall roadmap for integrating these generative AI products is actually a very familiar process. I would say that in general, the only differences are, if their differences are very small. So they're actually in maybe designing the right outcomes and the evaluation. That might vary depending on what type of LLM or generative AI solution you're using. But the actual full-fledged implementation of these tools follows sort of any just traditional change management or whatever process is already in place. And I think that's a key thing. So I wanted to talk through actually an impressive work that came out of Kaiser looks like a few weeks ago at this point. It was published on February 20. Oh, that's like last week, I guess. About using virtual scribes and the process that was taken to try to implement these at Kaiser. And I think that it follows a lot of these principles, and I think it's helpful to just talk through some of them and see, where we can improve on it or where they did a good job. So one of the things that I think is incredibly important in the context of generative AI tools and products is the identification of clear needs and goals. And so in this work, they actually talk about their explicit goals for the pilot. So facilitating engagement. So they want, growing sustained adoption of these tools. They want it to be effective at reducing the burden. They want to enhance the physician-patient relationship, and they want to maintain the quality of the notes that are being generated. One of the key things that I think is important to consider in addition to this is also what are you actually trying to improve here? So we can say that we're going to facilitate engagement or aim for effectiveness, but what is the return on investment in investing into one of these tools? Let's say the tool costs, $250 per month per physician that's using it. How can we evaluate the return on investment. Because although these are important goals to have, I think without a clear understanding of how to measure whether or not we have return on investment, I think is an important thing to consider as well. The next thing is, of course, we have to define what outcomes, safety, and like process metrics that we are aiming to improve. And I think this is where they could have gone one step further and talked about return on investment, although it may not have been the right venue for this. But before the study was run, they looked at several aggregate EHR workload metrics that they wanted to optimize for. So one of them being pajama time, where I think it's between outside of 7 a.m. and 7 p.m. How much time are people spending reading their notes, redoing the notes, for example, and spending time in their notes. And this is a key metric that they defined upfront before actually using the generative AI tools. They also planned to send out patient surveys to see whether the patients were more satisfied. And the key fact here, I think, is that they actually did this before doing the study. So it wasn't come up with the surveys as you're going, or just collect some data and look at it afterwards. It's important to identify these things up front. Otherwise, I think it becomes a little bit murky as to whether or not that generative AI product is good or not. I think that if you ask physicians when they first use it, overwhelmingly they'll be like, "Oh, this could totally save me a lot of time." But as weeks go on, is there sustained adoption? Is it actually affecting the process measures that you care about? And are you getting return on investment for those? So the one place where I think the evaluation is going to vary in terms of these generative AI technologies is how do you actually evaluate the quality of the output from them? Many generative AI technologies, as their name might suggest, actually generate some sort of output, like a note or some form of text, or even, let's say, in the future, video or something like that. How do we design evaluations, maybe based off existing evaluations, to try to quantitatively measure how well these tools are working? And so in this study, what they did was they took an existing tool instrument called the PDQI, which is the Physician Documentation Quality Instrument, and they added a few extra things to account for the fact that it was AI generated. So, for example, they added these two at the bottom. It says, is it free from hallucination? Is it free from bias? And they're using these existing tools in order to try to base it off of something that everyone is familiar with, but then also tailor it to this particular solution. And I think that there's going to be no one size fits all evaluation. It's going to come down to, again, the specific use case. What are the things that are important for making sure that this is a safe and effective solution in that use case? So here they came up with this instrument, which I thought was quite clever. And then so they showed that actually, on some things, there was actually a pretty large decrease in terms of pajama time, or the time outside of 7 a.m. to 7 p.m., but then didn't see a large difference or significant difference in terms of outside scheduled hours, for instance, and how much time they were spent during appointment related. I think the main effect was mostly the time they spent in the notes, and that's sort of obvious. I think if you're using the AI scribe, hopefully you aren't spending time in notes, but this is a nice verification. And again, goes back to a metric that was defined a priori, so before the study. As I mentioned before, hallucination is an inherent property of large language models. So I was curious to see whether or not they noted hallucinations, and they did. So, for example, in one example, they mentioned scheduling a prostate exam, and the AI scribe summarized that a prostate examination had been performed. So that's obviously not what happened. And there was a few other examples of this. So I think this is something that needs to be taken into account or factored in when evaluating generative AI, is planning for hallucinations. So what do you do? So, how do you prevent it? What do you do when it hallucinates? Is there a fallback? How do we ensure that people are actually reading the notes and not sort of like, getting lazy and saying, oh, the AI scribe will take care of it because I've seen it happen in, at least 70% of the times that I've used it, right? This is the type of thing that we want to avoid, and I think is important to design for. One of the things that is inevitable with some of these, anytime you're integrating a new product, I think, is having the implementation involve stakeholders and a large team to undergo testing and to actually integrate it. And so Kaiser did that. They ran a 2-week pilot where they had dedicated teams to oversee the implementation at each of the regional sites. And they provided technical support and training throughout the implementation period, which I think is incredibly important when you're coming up with a new or evaluating a new product, especially in direct clinical care, I think it's incredibly important to make sure that you have that training materials. And we've done that at DIHI for many of our models and noticed a huge effect of that instead of just introducing the technology as is. And so they did a 1 hour virtual interactive webinar with physicians in the practice. They had continuing education. They had patient-facing materials as well. But despite this, they still only had a roughly, let's say, 30% adoption rate. And I think that this is sort of inevitable in some sense. I think there's always going to be the early adopters. There are going to be those that are happy with their current workflow, or maybe there are too many steps. And one of the large factors I think here was that it wasn't directly integrated into the EHR, which I think is one of the number one. They said was like the number one complaint from people who didn't use it was, if I have to use another app on my phone and then copy paste it in, it's just too many steps. Like, am I really saving that much time at that point? So I think that's a very important lesson for the future. So, just taking a step back, I think when I think about how we should frame just in general the generative AI projects or the product evaluation, for example, the major takeaways that I see are that the implementation of the generative AI tools are in many ways similar to the implementation of tools that we've adopted in the past, whether that be other AI tools or new devices, and all of these change management processes that take place in the past have to take place again. Nothing serious has changed. In fact, the majority of use cases that use generative AI today will necessitate human in the loop feedback because most of them have humans in the loop. Things like virtual scribing, replying to in-basket messages, scheduling, all of these are going to require humans in the loop because of the fact that there is hallucination, there might be bias. This virtual scribe implementation by Kaiser was actually only able to work on English. So there wasn't any multilingual support. So this might be, part of the problem is that maybe we need to spend more resources and kind of make sure it works for people speaking languages other than English. That might be a good place to focus efforts. There's a lot of work that still needs to be done on that front. I think because of the hallucination problem, in my experience and sort of our experience, there's always going to need to be a human in the loop, at least for the time being. And I actually don't really see that going away. And I think that's going to be the case for many of these, unless the cost of getting one of these things wrong or making a mistake is quite low. That's I think is one case where you might be able to have a more automated framework. But in the cases where you're interacting with patients or this is going into the record, I think it's very important for there to be a human in the loop. One of the takeaways is that the evaluation is going to be dependent on your use case. There's not going to be a one-size-fits-all solution here. We need to think carefully about what are the metrics that we want to measure. Are those actually going to help us in terms of reducing physician burnout? How do you quantify that? How do you quantify return on investment on that? I think those need to be identified up front, and that's where a lot of the work needs to happen. And then I think the implementation, although it takes a lot of work, will at least have a clear answer as to a go or no go for the technology. And I think that's an important thing, rather than getting stuck in limbo and saying, well, it was kind of helpful here, it wasn't so helpful here, there were some downsides, and sort of being left in this continuous loop of not making a decision on whether to implement or not. I don't see automated evaluation happening anytime soon, again, for the reasons I mentioned before. And again, just focusing on explicit return on investment. One is the benefit associated with adopting technologies. How can we measure that? And having a very clear focus on that metric, rather than thinking about, is this, broadly useful or effective? So I'll just spend like a few, maybe 1 minute talking about where generative AI, technology is headed. There's been sort of two main trends in the past year about where these generative AI technologies are headed, which I think will eventually have an impact in healthcare. And they are going to, I think, require the same amount of detail-oriented behavior in order to really make sure that they fit our use cases. So one of the two main trends, one is that they're going to be multimodal. So OpenAI has recently released a text-to-video model. There might be things like video to text, but I could see things like reading radiology reports or MRIs, or even patient education videos, for example, could be synthesized. Text to speech. There's a whole, I think the future of generative AI is going to be multimodal. I think that it's still going to be challenging to integrating those into healthcare. The large language model use case, I think, is a little bit easier to understand. And the next one is that they're starting to become action oriented. So a lot of what we've seen so far is that generative AI use cases are um, you as a human interacting with the AI. So maybe through some prompts, or it generates text for you. But what happens when it can actually take actions? So I think, for example, in the EHR setting, will it be able to actually order things for you, or refill a patient's medication? As you can see, the cost of making an error in those use cases is very high. And so I think that action oriented, or LLM agents, as they're known as, might take some time before they really take off in healthcare, but I think for some of the more documentation or billing focused use cases, we might start to see a trend towards those. And the key takeaway, as I'm sure everyone here can agree with, is that as these tools get more and more sophisticated, the integration of these tools is also going to be a more sophisticated process. And I think only through very careful planning, evaluation, and consideration of what are we actually trying to solve here, will this actually be successful? So I'll stop there. I know I threw a lot at you all today, but happy to answer any questions ranging from the technology, how it works, as technical or non-technical as you'd like to get. I'm here to answer any questions, and I have my colleague Mark here as well, who can help answer.
Thank you so much, Michael. Wow, that was definitely a lot of helpful information called out. I want to just personally thank you so much for including a lot of visuals and examples in your presentation. That was really helpful for me for understanding kind of the training, the chain of thought training that it does, and then also kind of understanding those hallucinations that you were talking about. That was really helpful. So great presentation. Now is a great time for questions. So folks, as we're talking, please feel free to use the chat and Q&A. We are getting a few in, so I'll go ahead and read those out for you, okay? Question number 1, what should be the visibility for the patients when AI is used?
Yeah, that's a great question. I think this will come down, it's one of the places where some of these virtual scribe products are differentiating themselves. Is some of them provide a patient summary for the encounter as well. I think that same thing goes for when you're evaluating some of these use cases on the clinician side. I think the same things need to be on the patient side. Is it providing them with information that's factual, that actually helps address some of their concerns? And also, what is the risk if it says something that didn't happen? I think I personally get worried when we use generative AI for patient-facing tasks, because what if it hallucinates? What if it gets something wrong? What are the checks in place for that? Are there liability concerns? These questions start to come up. So I think that thinking about all of any sort of interaction between any part of any person, patient, provider, whomever, it's important to think about, what are the risks associated with what if it doesn't do the right thing? If that risk is deemed low enough, I think that it could definitely be beneficial for patients to see a response. And I think the Kaiser implementation did that. They actually provided a patient-facing summary of the encounter.
Michael, I can speak a little bit to what we're hearing from other organizations too. So one thing to call out is that the question of disclosure and consent for patients in the use of AI in clinical care is much broader than just generative AI. I think it's well understood that today there is minimal disclosure and there's almost like no patient consent for use of AI. But there are some questions about, are there certain use cases that are higher risk that there needs to be disclosure or consent? I will tell you that we hear from a lot of organizations that we work with through Health AI Partnership that certain types of AI are so core to operations in terms of like autocomplete. When you think of AI broadly, there's a lot of automation that it may be overly burdensome to be disclosing to patients. So I think it depends on the use case. And then specific to generative AI, I can give you just 2 different examples. So for example, UC San Diego provides disclosures on all in-basket messages that were drafted by an AI large language model, whereas University of Wisconsin does not do that, but they have other language about how the technology is used in clinical care. So I think it's today there's not like a best practice yet. Different organizations are taking different approaches.
Great to hear. With that, I'm going to jump a little bit out of order. Oh, I think we have time to get to all the questions, but since it kind of relates, what mitigations can you think of regarding privacy and data leakage when using LLMs for patient health information?
Yeah, that's a great question. Actually, I think this is one of the main challenges with building some of these technologies today is much of that's the best performing tools. So when we think about OpenAI, GPT-4, or Google's like Gemini models, these are at the top of the leaderboard, let's say, for in terms of state-of-the-art performance. I think that it's going to be difficult to use those tools directly in clinical practice. I mean, you can imagine, there's no way that you would take a recording of your interaction with a patient and then upload it to some of those, because that's a direct violation. So I think there's sort of two main approaches that institutions are taking. One is signing agreements, for example, with Microsoft, which has access to a PHI compliant version of GPT-4 if you sign particular contracts with them, in which case you can build on that technology. The other is to actually use open source models. I think some of these companies are able to make sure that basically it's just software running in a server somewhere. There's no information being leaked, kind of like it could be the same server that your EHR runs on, for instance, behind the same firewalls. So there's going to be some tools developed in that space as well.
Great. All right. Our next question, are you able to give some more examples of the hallucinations? Can you explain a little bit more in detail?
Yeah, so hallucinations, they vary in their forms. There's actually some interesting, research that kind of tries to categorize the different ones. I think that, you can think of hallucinations really as, I like to think of them broadly as where the LLM just fails to do the task that you asked it. And there's actually there are many different ways that can happen. So the ones that I gave were it can get facts wrong, and this is more potentially a function of the fact that it's hard for the LLM to recall like what it saw during the training process. I think the more difficult one is this faithfulness hallucination. So when you're giving it information in the prompt and you're saying you're asking questions about it, and this is the main modality for most of these generative AI use cases, you want it to at least perform the same as if you were reading the prompt and answering those questions. But sometimes it can just get it wrong. And I think this is, again, a function of the fact that the way that these large language models work is that when it's generating the answer, it generates one word, and then it says, okay, given all these words, in the prompt and the word I just generated, what should the next word be? And then it takes all of the words it just generated and says, okay, what should the next word be? So it does this in what's called an auto-regressive fashion, meaning it takes everything that it saw before, generates one word. Then it takes all of that and generates the next word. And at each step, it's saying, what is the probability of the next word being generated? And I'm just going to roll a weighted dice, basically. And, maybe 99% of the time, the word should be the correct one. And then maybe 1% of the time, it's not correct. Or maybe it's even less than 1% in many cases. But fundamentally, that's how they work. So there are going to be some cases where it gets it wrong. And it's very difficult to make it not do that, is the point.
Mm-hmm. Very cool. It was very helpful for me when you said the sample probability distributions or distributors, I think, earlier, to kind of understand, and I appreciate that you have examples on screen. It's really thoughtful to think about how it is trained and then how it then spits out everything. Great to see. For our next question, I know we are kind of focusing on more medical healthcare AI, but we love the presentation. We thank you for it. There is, they see a potential in using this technology for connecting patients to social services. Have you seen examples of that? Have you done any work in this? Yeah.
Michael, can I start on this one?
Absolutely.
Yeah, so I'm going to drop a link. Actually, I don't know if I can put a chat for everybody, but the website is cresta.com. So one of the organizations that we work with, they have looked at this product for use in call centers. So I think it's similar to the question of social services,
Mhm.
where if you have people who are trying to provide folks information about resources that are specific to them in their geography or for their context, what they use the tool for is to gather that information and try to tee it up for the person on the phone call. So the algorithm is getting fed the transcript of the call, and then during the phone call it's providing these recommendations based on the types of services that the person that are related to the conversation. So that is something that we are actively aware of, that folks are trying to use these tools for.
Yeah, I think the only thing I'll add is just that we do see some of this. I'm not exactly familiar with some of the examples. I will say from a technical standpoint, this seems like a great use case.
Mhm.
You just have all the potential information, and then your instructions for how you would send patients these and direct them to certain services, and then from there, I think it should be fairly straightforward. So this is something that I think you could even try to pilot yourself. There's these things known as GPTs from OpenAI, where you can put a bunch of documents in and give it instructions and say, hey, when I interact with this, be sure to recommend these resources for these patients. I think that you could play around with that idea yourself, and I would imagine that there are going to be solutions around this space.
Yeah.
Michael, can you give folks some context of how we're starting to try to understand those capabilities at Duke?
I think some of the things that we're doing is around like in-basket messaging. So sometimes we have, for example, in the endocrine setting, when someone is having issues with their continuous glucose monitor, we can actually read the messages using some of these LLMs and say, oh, this message actually should be directed to, these members of the clinical staff, which help with that, rather than, burdening the inbox for some other people. So although that's not done exactly on the patient-facing end, I think it's sort of, a related technology. And using some of the techniques that I described in this, you can be fairly prescriptive about how you want that workflow to work. For example, saying, if you have a medical question that you're asking about, that supersedes whatever question they might have about their glucose monitor, send that to the provider.
Mhm.
But if they're just asking about their device, then we can just route that message accordingly. So there's definitely some work being done in this of like call center triaging, connecting people with services space.
Definitely a lot of great application potential there. I'm not seeing any more questions. I do have a comment that was posted. It says, think Family Feud, and the survey said, as a counselor, I would like to pose questions from live group therapy sessions when participants seem to be stuck. Replies from a chat might open up difficult answers to difficult questions. It was an anonymous attendee. If you'd like to add more on that, we'd love to hear. Last call for questions. I'd also like to pull up our slide, if that's okay. I will share with our attendees, this recording will be made available on our YouTube. We will also share it out. I believe they have also shared their contact information in their presentation. So if you have more questions for Mark or Michael, you can contact them or CTRC. We are here for you. California Telehealth Resource Center is here to be a resource for all digital health success. Please join us for some upcoming learning sessions. You will see Mark's face again in our AI series. We have 2 sessions coming up: health equity across the AI life cycle on March 19th. We also have organizational governance of AI happening in April. I also want to call out that there is a regular standard outside of AI webinar happening on March 7th, titled Success and Sustainability, Digitally Provided Genetic Services, Overcoming Obstacles to Patient Access and Precision Medicine. We will be joined by David Flannery from the Cleveland Clinic on March 7th for that presentation. So please register, join us, come hang out on Zoom with us some more. Next slide, please. I will also share that CTRC is having some in-person learning opportunities. So unfortunately, we already passed Sacramento. So if you're in Northern California, you may have to drive a little bit. But we do have 2 in-person opportunities in Fresno and Los Angeles coming up. If you are really looking for hands-on in-person opportunities to connect and learn about digital health opportunities for your health center, this is a great one you don't want to miss. And it's free, and we'll even give you lunch too. So definitely join us for that. And lastly, I would just like to really thank Michael and Mark for such a great presentation today. This was so insightful. I really just want to call out right at the end, I know you did some summarizing, but your attention to the human connection, your attention to quality metrics and real considerations for this technology were just so thoughtfully presented here. It was educational for me. I'm sure everybody who joined us today really enjoyed it. So just thank you so much, and we'll see you again. So thank you.
Thanks so much. Thank you for the opportunity.